This is fine. 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 This is a poor substitute for therapy, but an excellent substitute for other podcasts.
We're not like other podcasts.
Join us as we find the answers to the universe's biggest questions like, is butter a carb? Does crying burn calories? And what the fuck am I doing with my life? We're here to be your part-time therapist, astrologer, concierge doctor, and fairy godmother. Do you need someone to validate you today? Cool. Come on in. We're fine. This is fine. Hello, BBs. Welcome back to our second half of our interview with brilliant physician, surgeon, and hormone expert, Dr. Catharine Marshall, MD, board-certified OBGYN. Dr. Marshall is known for her laparoscopic surgery skills and is a member of the Scripps Minimally Invasive Robotic Surgery Program. She joined us for episode 21 to debrief us on all things hormones. So if you want that foundation before you get into today's content, definitely go back and listen to that one. When you pause this episode, don't forget to subscribe on your way over to episode 21. Thank you. Okay, we're back today to talk about a number of women's health topics, specifically your hormonal health, with questions submitted by This Is Fine listeners. Listeners, they're just like us. But seriously, thank you to everyone who submitted your questions on Instagram, via text. So happy you are part of this community. We're getting into hormonal birth control, treatment of different hormonal imbalances, cycle syncing workouts, fertility, and postpartum changes. Dr. Marshall, welcome back. Thanks for sticking around here for part 2 of this women's health series. Again, how are you feeling? Are you fine?
Totally fine.
Totally fine. Super fine. Let's just jump right back into it, shall we?
Sure.
Okay, so we just talked last episode a bit about birth control, and this might be a touchy subject for someone who does prescribe birth control, but some of our listeners, one listener in particular, asked, why do most OBGYNs prescribe birth control as a first response to PCOS and other hormonal conditions instead of finding another solution?
Yeah, it's a great question.
Yeah, someone's thinking.
Yeah, someone's thinking. Exactly. So for PCOS, the big deal with it is too much testosterone and irregular cycles. And the pill is perfect at making that
handling both. Yeah,
it absolutely handles both, and puts your ovaries on ice, saves them up for the future, and so it's a great choice because it will immediately clear up acne for people, will immediately help with irregular cycles. It's not fun to have irregular cycles. Right. A lot of times they're heavier when they come.
Painful.
They're more painful when they come. You're also always wondering if you're pregnant or not and things like that. So, the invention of the pill, really one of the most wonderful things of the 20th century. So
it's an immediate solution to a lot of symptoms.
Yes.
Do we know what causes PCOS in individuals? Like, is there a way to target that root concurrently while also immediately treating the symptoms?
Yeah. So we don't know for sure what causes it.
So that's probably a big reason why we reach for the solution.
Big reason why we reach for the solution. There are non-birth control pill solutions. And, going back to, what we kind of know about the PCO, circling back to that insulin, there's definitely a link with obesity, having a high processed food diet, lots of carbohydrates, high fructose corn syrup, these sorts of things can start women on the road to, they used to call it Syndrome X, where you keep gaining weight, you get type 2 diabetes, you get problems with your liver's handling of cholesterol, and you get high blood pressure, problems during pregnancy with, that sort of thing. And then, heart disease. So it's a bad syndrome. You don't want Syndrome X. And so we're always trying to address that, and believe it or not, thin women can go on to develop this also. 80% of women are at risk of having these kind of adverse things happen in the future. So, again, lifestyle is a part of it, but, I can't change the advertising industry.
Right. Or the
I
food
can't change
industry.
the food industry.
Right.
Although a lot of times people will come in with their Jamba juices, the whole, 2,500 calories of sugary, stuff,
Right.
and protein powder that they think is healthy and,
Right.
and whatnot and wonder, it's, I like to recommend, I like a book called The Obesity Code by Jason Fung. People are upset. They're like, I'm not obese. It's like, but it explains why insulin is important for balancing and explaining what's going on with the polycystic syndrome. And then what else? So I prescribe metformin for a lot of women who don't want to be on the pill.
Right.
That is, as we discussed in a previous segment, a wonder pill that basically stops us from having these huge insulin surges. And it has side effects. It causes bloating and diarrhea and things like that for women, especially the first week it's taken.
Right.
But it is one of these, wonder drugs that, that's considered anti-aging and things like that. And it turns out there are also things like, cancer survivors who are on metformin are less likely to have their cancers to come back and things like that. Again, it has to do with the insulin.
Mm-hmm.
Same thing, intermittent fasting, breast cancer patients who intermittently fast 14 hours or, 5 days a week are less likely to have their breast cancer come back.
Wow.
That was a study out of UCLA. So, definitely insulin is hugely important. And when people may, demonize the high fructose corn syrup and things like that, it's like a little of it's probably fine.
Right, of course. The balance.
But it's all about, the glycemic index and what's happening with the insulin.
Yeah,
so,
making sure that healthy choices are the bulk of your choices while still indulging and living a little bit, I think.
Yeah. And then to digress, we talk about, GI health and having the right kind of bacteria in your intestines.
Mm-hmm.
And things like high fructose corn syrup actually pass into your colon. That's not good for what's growing there.
Yeah.
And it's also why we think there's such an explosion of colon cancer in our 40-year-olds and whatnot has to do with that sugar is supposed to be absorbed in the stomach and in the upper GI.
And it's not. Because
it's in such high quantities and so potent, it's detected in the colon, which is it's not supposed to be there.
Wow. Yeah, the food here, this is another rant for another day for me, but yeah, the food that is available to most people in the U.S. is not the most optimal for our health.
Well, and then the portions are absolutely wrong.
And things that are advertised to us. It's interesting just seeing, different approaches to food while traveling has kind of opened me up and made me think differently about my diet. And if I'm going to have a treat like soda, I'm not a soda person, but I love Mexican Coke. And I was trying to figure out why I like it so much. And it's actual like cane sugar versus the high fructose corn syrup. So I feel a little bit better about it. But yeah.
Sure. A special thing, but a daily thing,
Exactly. That's so hard on your body.
Not so good.
So in general, obviously like lifestyle changes are going to help target the root. I also wanted to bring up, I didn't know if this was like medically accepted, but I got a 23andMe result on my health panel that said you're very likely to have PCOS.
Interesting.
Which to me indicates like, oh, maybe it's just a genetic thing.
Well,
is that something you're familiar with?
Yeah. I mean, that's really, really interesting.
Right? It didn't say anything like nothing for diabetes, like totally normal and like other. Like,
I wonder what gene it was they were.
I know. I'm really curious too.
Now I want to see that.
Maybe I can bring it up.
There's definitely been very interesting data looking at, sort of metagenetics, like what kind of environment did you, come to be in your mother's womb.
Oh, like, is that epigenetics as well?
Yes, exactly.
Okay.
I can't believe I just said it.
No. Well, you actually taught me the word epigenetics, which is why I was like, wait.
I need coffee. You're right. It's epigenetics. And so the idea is that, for example, if the father smoked when, that sperm fertilized the egg, there's like more endometriosis. And if the mom had a lot of Cheerios when she was pregnant with you and not apples, then you're more likely to have PCO if your mom had this. So there's a thought to be a link about that as well. Well, we certainly, a lot of times when women have like more hair, or make more cysts. We'll say like, well, how about is it in your family? And a lot of women like Mediterranean and whatnot are going to have sort of more oily skin, more, more hair growth. There's sort of subtle genetic differences.
Right. This is so interesting. Yeah. And the whole epigenetics thing is fascinating, but that would make me think it would lead to a specific gene that 23andMe was talking about. And they didn't. They're like, we're looking at a whole bunch of things.
Right.
Yeah.
I'm sorry. I'm not familiar with that.
I fully just put you on the spot with brand new information that isn't like widely accepted by the medical community, just purely out of curiosity. It was interesting that I saw, because almost everything it said was pretty spot on, except for the fact that it's like 80% likely I'm a ginger. I do have red in my hair, but it said it was like
you must have Neanderthal.
Genes. Got a tiny bit in there, but also like very Irish.
Well, and did you see the Nobel Prize is just this paleogeneticist who's found a whole nother, race besides Neanderthal that we have the genes of. It's really,
that's so cool.
Yeah, this is the Wild West of genetics now. It's a very interesting time for cancer, for everything. So much amazing changes and developments. Yeah, exactly.
So cool. And I love how we got here from like prescribing birth control. Is birth control also prescribed kind of off the bat for endometriosis?
Yes.
Okay.
Yes.
Same kind of thought process. Like, we don't really know what's causing it. We have to target immediate symptoms to get you relief.
Yeah.
Okay.
Yeah.
I mean, that
and
makes
also, there are studies that show that there's less progression of the endometriosis on the hormonal birth control. The drospirenone ones are really wonderful for endometriosis.
For targeting that.
Yeah.
Okay. So I think some people might come to this kind of question with a frustration, like, why is my doctor just giving me a pill instead of figuring out how to undo the problem, right? What do you say to patients who come to you with that kind of mindset?
It's hard to develop credibility with someone when you don't have that much FaceTime with them to explain things.
And that's what you said in our last episode, that you only get a short period of time with your patients when you wish you could spend an hour with each one.
I once got this review. They were so upset that I gave them birth control pills. It was someone with oligomenorrhea.
Okay.
And I had samples and I gave them, and then I prescribed it. And I wanted them to do it for a couple of months, sort of to reset.
Mm-hmm.
Because a lot of times that's, a trick you can do that will reset things, and then people can get pregnant. And
like jumper cables for your ovaries.
And the review was like, she's such a terrible doctor. She gave us birth control pills, and then the next time we had an ultrasound, we were pregnant. What a terrible doctor. It was like, we went off this terrible medicine after 2 months, and then she was pregnant. And it was like that was the plan.
I did my job. Yeah, that is a really tough thing for, especially I would say in our medical system with insurance and everything, for doctors to be able to spend quality time developing relationships with their patients.
Yeah.
You're kind of cornered in a way, aren't you?
Yeah.
So is there a way for you to prescribe this medicine while a patient can also start to explore root causes?
Yeah. I mean, I try to give my patients some information about PCO when we come up with a diagnosis, because a lot of people are relieved to have a diagnosis. Some people are really, really upset. And, that goes with a lot of, conditions in the diagnosis in the gynecology office.
It feels validating to have some kind of answer and oh, I'm not crazy. This isn't in my head. This is a real thing. But at the same time, there's a gravity to having that label as well.
Yeah. Yeah, exactly. To know that you have to be more careful about your blood pressure and things like that. The rest of your days, if you've got this diagnosis, is heavy for people. So again, I try to give handouts or basically through our electronic medical record. It'll be something they can see on their interface. But it's really difficult to cover ovarian physiology in a 15-minute visit.
Right.
But what I can tell patients is that, the pill, like I said, if I was the, Surgeon General, I would recommend that all women, no matter where they are, that they use the birth control pill for a couple of years just because of the beneficial effects.
And you can get that from short-term use?
Well, the best data showing that it halves the rates of ovarian cancer and uterine cancer is 2 years.
So you can cut your cancer risk in half with 2 years of birth control?
Correct.
Wow. Okay.
Yeah.
So that's a really big pro. Are there cons? Are there long-term negative effects of taking birth control?
Well, there's no free ride. Any pharmaceutical is going to have risks and benefits.
Right.
Some women will have, a bad reaction to one pill versus another, more emotional issues with one versus another. And, we divide almost all there's some newer pills that have a different estrogen than the ethinyl estradiol, but most of the combination birth control pills have ethinyl estradiol, same estrogen, and then different progestins. And the different progestins can have different side effects. Some of them will cause a little more acne. Some of them will be completely anti-acne.
Okay.
The one that causes a little more acne, there's like almost no spotting on the pill. And then ones that don't have that benefit, maybe there's spotting and less acne and
this is where the nuance comes in.
Yes. Okay. So if you hate the pill you were given, please don't write it off and say, this is hopeless. No pill will ever work for me, because there are literally like 20 or 30 that are commercially available that are distinct from each other.
Wow. And I'm glad you brought that up, because a few episodes back, we talked about antidepressants and how when people are going on a mental health medical journey, finding the pill that works for you is also very difficult. And a lot of patients get really discouraged in that first 6 weeks to 6 months if something is not working, and then they have to try something else. I feel like there are some similarities here where you really do have to figure out what works for your body through a bit of trial and error.
Yeah, it's hard to hack your body and figure out what works. I mean, there's been hope of, genetic tests to figure out which antidepressant will work best for which person and things like that. I wish we had that kind of technology. We do a pretty good job guessing most of the time. Most women like the prescription they've been given for birth control, and will continue it, and will do so safely and happily. And as soon as they stop taking it, if they want to get pregnant, if they're at a reasonable age, they will get pregnant.
Okay. Yeah. I'm glad you brought up reasonable age. One of our listeners said, is geriatric pregnancy really 35?
Yeah, that's such an ugly name.
It's such a sad name. Like 35 is so young.
Yeah, but there are metabolic changes. There's aging of our cells. Your immune system has changed as well. And so when you are 35 and trying to conceive, the enzymes that recharge, the vitamins that recharge enzymes and things like that, they're not at the same level as when you were 21. So there are numerous studies that show like folic acid requirements when you're under 35, when you're in your 20s, are 800 micrograms. Okay. And when you're 35 plus, if you're only on that amount, you're going to have a higher rate of birth defects.
Wow.
But if you take 3 or 5 times that dose, then you can bring that level of birth defect down, heart defects, spina bifida, cleft palate. So, just that alone, to understand that there are changes in your body, you're more likely to have problems with high blood pressure. You're more likely to have immune problems at the end of pregnancy, issues where you reject the pregnancy. So it's high risk. So that's the way they call it, a high-risk pregnancy.
Okay.
I don't think no one uses that term anymore.
Geriatric?
Just because it's, we call it advanced maternal age, just because, it sounds pejorative.
It really does.
And really, it's becoming more and more of a norm to have your kids later in life.
Right. So have you seen that just within your practice, that your patients are older and older as they're conceiving?
Oh, for sure. Yeah.
Okay.
Yeah.
And still things are going well? It's like normal?
Well, it's a difficult conversation to have, to say, some people are going to have an easier time getting pregnant when they're older, and some people aren't going to have an easy time. As I said, having the polycystic ovary syndrome has a nice side effect if you're not spending all your eggs at once, which is good.
Your internal egg freezer.
Right. Turns out women who've been on the pill also have a pretty easy time conceiving as well. Their ovaries sort of been hibernating. They do lose follicles. They have what's called follicular atresia, but there's not the scar tissue that occurs from ovulation. When we ovulate, we make a cyst on our ovary. That's painful for quite a few women. Basically when that bursts, it's sort of like you've had a blister on your ovary, and it's so sort of inflamed and injured the next month when there's a contest to see which ovary has the dominant egg,
the golden
egg. Highlander.
Yeah.
Yes, so there will only be one.
Yeah.
It won't be the one where there was just an ovulation, usually because there's so much inflammation and whatnot. So
that's why it alternates.
That's why it alternates.
Okay.
And that's why we like the pill for endometriosis, is if you can sort of, calm that down, that
inflammation,
that releasing of the eggs, that inflammation, that can be quite helpful.
So circling back, I got us a little bit off track with the geriatric pregnancy, but kind of coming back to those long-term side effects of being, let's say someone is on the pill for 10 plus years. Do we have any more information now versus 10, 20 years ago about what those long-term effects could possibly be?
In general, I think the feeling is that it's very safe to be on the pill for 10 years for contraception. The association with breast cancer is there. Particularly the older you are when you're on a hormonal medication of any type.
So potentially higher risk if you're on long-term for breast cancer.
Yes, yeah. Okay. So that's another reason why I encourage my patients in their 30s to think about vacation. Vacation from the hormones.
Yeah.
And it doesn't matter what hormone it is, if it's Depo-Provera or Mirena, they're all associated with
a similar risk.
Yeah.
Okay. And that's for long-term or in general?
Yes, long-term, and also at certain, at a certain age. It is a risk factor for estrogen-sensitive breast cancers.
That's good to know, especially for any women listening in their 30s.
Yeah.
Talk to your doctor.
Now, we have very low-dose pills, and much lower than they used to be when they first came out. And so that risk is smaller than it used to be, but there is still a risk for any hormones that you're using when you're in your, especially late 30s and 40s.
Okay.
What else? Blood clots are an issue with combination birth control pills.
Right.
So it's important to be aware if you've got a family history of strokes,
right?
Blood
Migraines
clots
with aura.
Exactly.
Mm-hmm.
Exactly. That you have to. But that being said, some women will do much better on the pill, will have fewer migraines with aura on a low-dose birth control pill. So it's all sort of a risk-benefit analysis. My feeling is if you really need it for contraception, then that's great. But if you don't need it for contraception, then, it might, if you're someone with migraines and whatnot.
Right. Look for alternatives.
Exactly.
Okay. So moving toward our cycles, exercise, I got questions from listeners about the impact of these hormonal fluctuations on our muscles, working out. Specifically, one listener shared that she has had patellar tendinitis and muscular breakdown in her knee, the tissues around her knee, due to menstrual phase exercise. Do you have some intel on that?
That may absolutely be a thing because as we discussed earlier, when your hormones are, cratered, that there's sort of less juiciness to all of your organs, all of your knees and joints and exactly. So, and then, I've also had a patient come to me and say her TMJ was really bad in that menstrual phase, and that when she had surgery, her surgeon said it was the pill that was her low-dose pill that was associated with, because there was low levels of her natural estradiol.
Wow.
That joint was sort of not getting like the blood flow it needed, sort of more avascular and things like that. So it's like, it's complicated. there's a certain level of hormones that are sort of make things sort of juicy and work well. And then the very low dose birth control pills, yes, they can sort of dry things up. Some women on very low dose birth control pills can have even sort of vaginal dryness and other symptoms like that. So we're looking at a safer pill for cancer risk and for stroke risk and things like that, but they can have, side effects.
Impact your muscles, perhaps.
Yes. And as we discussed before, the oral contraceptives, actually all the hormones, but especially the oral contraceptives, will stimulate the liver to make something called sex hormone binding globulin, because the liver gets the medication and says, oh my God, I'm being poisoned. And sex hormone binding globulin loves testosterone like 10 times more than estrogen. And so it really will bind up all of your testosterone. And that can cause changes in your brain testosterone and in your muscle testosterone. And so that can change, obviously we think peak muscle mass can be different, but this is not, women aren't terribly muscular compared to men.
Right.
And I think that these are very subtle differences. And they would not keep me from recommending the pill to an athlete or to someone, working out. On the other hand, if you're a bodybuilder and you're hitting a wall and you're on the pill, then, maybe a pill vacation might be helpful.
Okay.
And some purists don't want to be on any hormones at all so that they experience the natural testosterone in their body their whole life. And that's absolutely, acceptable, choice as well. So if you're someone who, gets a recommendation for the pill and you, really don't want it for those reasons, there's certainly other ways to handle PCOS symptoms. We talked about the metformin. We talked about, seeing a dermatologist. There's another medication called spironolactone, which can definitely inhibit androgens in the skin. But it messes up the cycle. So there's always going to be a side effect.
Pros and cons. So for the people who, whether or not they're on any kind of hormonal contraceptive, let's say they are trying to cycle sync their workouts because they have had this kind of, I don't know if it's muscular atrophy or muscular damage from doing a certain type of exercise on the wrong phase of their cycle. I don't know if that's from like the drop off right before menstruation starts. I've seen, the videos on social media about cycle syncing. I've heard more and more about it just in the general media, where essentially you do a certain level of intensity based on your follicular phase, your ovulation, your menstrual phase, and I'm missing one.
I love it. I think that's really cool, actually.
Yeah.
I think that's a great body hack, you know. If you're very attuned to your exercise. I think exercise when you're on your cycle and when you're in your luteal PMS phase is very important for mental health. I used to always need to take a run away, at the start of a cycle.
Okay.
So, but to run a marathon, that maybe not a great choice when you're on your cycle.
So the cycle syncing essentially says to do more gentle workouts like yoga, long walks with your dog or by yourself with your girlfriends, kind of a lower key workout versus the high intensity that I believe, and I could be getting this wrong, would be done around ovulation. Okay.
That probably is a great idea.
Okay.
Our immune system is lower when we're on our cycle, and women do tend to sort of catch colds and things like that more easily around that time when, again, estrogen's important for our immune system too.
Okay.
So the idea of not sort of doing exercise bulimia when you're on your period is a good one. I think totally. You don't want to overdo it when your body's already having that stressor.
Right.
So I think that's probably a great idea. Cool. That being said, I'll say personally, sometimes you do just need to, get on the bike and sweat it out when you're starting that part of your cycle psychologically.
Right. Cycle on your cycle. No, I love this because it is kind of a fringe concept right now. And the fact that you can look at this with your medical background and say that, yeah, that's pretty cool. Love that. Okay. So let's move on to another listener's question. She is wondering, is there anything about pregnancy or postpartum when it comes to mental changes that people don't talk about or women should know more about? Do you have any intel on the mental health, emotional health, ups, downs that we're not discussing more commonly?
Yeah. I mean, a postpartum is harder than pregnancy for sure.
Okay.
I think the lack of sleep definitely can tip people into, adverse, mental states for sure. We don't talk about how difficult breastfeeding is,
right.
And really how important that is to try to do. What else do we not talk about postpartum? Well, I mean, it's good we're talking about the postpartum depression more.
Right.
It's a real thing.
Much more popular conversation now.
And it's more important to have the mom on her medications and the baby on formula if necessary than to have people at their wits' end.
Right. Really depressed.
Yeah.
Right.
The other thing that's not sort of politically correct to talk about is how our brain sort of rewires when we have a baby, how we joke about it, the working moms at the hospital, I have beta brain, can't remember, words, or your brain just sort of...
Like aphasia, brain fog.
There is definitely a brain fog that happens following childbirth. And it's supposed to happen that way. Your brain is supposed to sort of rewire so that you just completely love on this creature you created.
Yeah, totally.
But you hate to talk about it at work because you don't want to be...
Well, yeah, you're a woman in a workplace.
Your best.
Yeah, exactly. You have to be at top form all the time. That makes a lot of sense. But the postpartum brain fog sounds like... I've never heard about it. I've heard about the postpartum depression, but the brain fog and forgetting words, I mean, that's got to feel validating to anyone listening right now who is going through it or who has gone through it.
You're fine. It's temporary.
It's temporary. Everything's fine. That also kind of reminds me, do you have to come off of your mental health medication when you are either conceiving or pregnant? Like, let's say you're on an SSRI or an NDRI. Is that something you have to stop taking?
Ideally, you want to get off these medications. And there's certainly some atypical medications and seizure medications that are absolutely prohibited when you're pregnant. You should never be on them. That being said, sometimes people are on these medications, and extra folic acid can be helpful. And actually, folic acid is super important for mental health as well.
Yeah.
The B vitamins are just... they're almost more effective than the antidepressants for some people. So there are studies about the different medications, and Prozac is probably the one that's been the most studied. And again, it has to do with its pros and cons. There are some adverse effects for the offspring with these medications for some people. And so it is advised to go off of them, or, at least to taper down.
Right, like wean off beforehand.
Okay. Exactly. I've had hundreds of patients who remain on their medications who have perfectly fine babies.
Oh, that's good to hear.
We're not trying to guilt people or anything like that.
Yeah.
But it's just like, all the over-the-counter medication. You just want to stay away from
just to
everything
be as safe as possible
when you're pregnant.
Yeah, that's good to know for anyone who does have a mental health struggle, who might be a little bit afraid of this. It is part of the process, and definitely something you should work with, like your mental health care provider, your obstetrician. It's not really widely discussed having to wean off of antidepressants, anxiolytics, any other kind of mental health medication, and then go through 9 months without that medication, possibly longer, depending on breastfeeding and your, the state of your health.
Right.
Yeah.
Yeah. It's quite a difficult thing to address. Again, in an office visit, it's hard to address completely as well that, ideally you taper off of it. But if if it's not possible, if you're suicidal or if you can't function at work or other, in your relationship, then you can continue it. And you have to work with your doctor on specifics about your specific medication.
Right. That's so important. It's so case by case.
Same thing with nursing, because most of these medications can be present in breast milk as well, to figure out, what's right for you as far as staying on medications and choices like that. But I would say, having offspring is a really amazing experience that is challenging, but worth the uncertainty. No one has any guarantees that anyone's going to have everything be perfect. And a lot of young women are on these medications. So embrace the journey. You're fine.
Everything's fine. No, I love that. Last question. This is a little bit more general about coming back to hormonal health and the things that we can do to promote better hormonal health, menstrual health. There's a lot on social media and in the media that kind of pushes to extremes. We're talking about cutting out entire food groups. And I know that lowering sugar, obviously, is a big deal with in terms of insulin. But looking at these extremes where it's like, okay, I've got to cut out dairy and gluten and only eat X, Y, Z. I feel like a lot of that's coming from fear, but I would love to know your opinion on that.
I'm not a nutritionist or a gastroenterologist. I do see patients that have this orthorexia or absolute obsession with eating correctly. I think that it is sort of a version of obsessive compulsive disorder that feels right in the moment, but can be very disruptive and is not necessarily the healthiest.
Right. It's like extreme health isn't healthy almost, right?
Nothing in excess except for moderation.
Yeah. So would you say, I guess the antidote to that in my mind would just be doing the things that make the rest of your body healthy will in turn also make your hormones and your menstrual cycle healthier, right? Like regular exercise, the back to basic stuff. Like we're exercising, but we're not doing too much. We're eating well, but we're not going to extremes like orthorexia. We're focusing on sleep and self-care, but not so much that it does become a compulsion. Does that sound medically sound to you?
Absolutely. Yeah.
Cool.
Yeah.
That's like my general coaching advice, but I don't have that MD, so I need to make sure.
But the choir who's working hard, we still need to hear these messages like, oh, don't drink every night.
Right.
And don't, you need to hear it from your friends. You need to hear it from your colleagues. You need to, have the good behaviors reinforced for sure.
Yeah.
But, I imagine we probably are preaching to the choir. The type of person who listens to you is probably very mindful of their diet and things like that.
Yeah, I think we're living in a good balance here.
Yeah.
We like Taco Bell and we like, a good salad.
Precisely. Oh, yeah. If you want to track your carbs, I think that's not the worst idea. There are apps on the phone.
Right.
Just like you can track your cycle, but there are apps like Noom that you prescribe to, or MyFitnessPal,
right?
Which, if you do not want to count calories, you can at least use it to count sort of your macros.
Okay.
And that's free.
Right.
And I think that's really helpful to sort of, realize where the sugars are coming in.
Right. Take inventory without letting it become an obsession.
Exactly.
Right. Especially if you are struggling with some kind of imbalance. If you're doing okay and you're just like, oh, I just want to check in with my, my hormonal health, would you also recommend taking inventory of macros?
Again, I'm sort of obsessed with insulin.
Yeah.
I think if we handle that the rest falls into place really well for most people.
Yeah, that's the thesis statement of the day.
That is the thesis statement. And I wish that that was emphasized in college and high school and whatnot.
Such a good point.
I mean, with 50% of the population going to need insulin, soon, we should understand that. Hormone the best.
Okay. Well, good to know on the hormone talk. We didn't think we were going to be talking about insulin, but here we are.
I'm not an endocrinologist, so.
But this is part of your field.
Yes, absolutely.
Massively. Dr. Marshall, again, thank you so much. This is so educational, and you are providing what we didn't get in school for free. Thank you for being here.
My pleasure.
Okay, sweet angel listeners, mommy loves you. Go schedule your annual check-in with your gyno and then go treat yourself for taking steps toward handling your health. You're a rock star. If you loved today's episode, please share it with a friend who can benefit from this information. Don't forget to leave us a review on whatever platform you're listening on. Subscribe to get the latest episodes. And if you're feeling extra committed, find us on Patreon, patreon.com/thisisfinepodcast. Thanks for tuning in to this episode of This Is Fine. I've been your host, Dominique Michelle Astorino. We're based in San Diego, recording in studio at DLI Productions in Pacific Beach with Emmy Award-winning sound designer Dan De La Isla. This is a comedy and advice podcast, but for legal reasons, this entire podcast is a joke and none of it is medical advice. To download the transcript or learn more, visit thisisfinepodcast.com.